Gentlemen, we're going to go and start. We're already 15 minutes behind. I'm honored to have Professor Habullah with me from the AUB, and our Dr. Hindawi, is that correct? Yes, sir. And Dr. Khalid Hindawi from Egypt. Our first speaker is a great friend of us, and he's from this country here, from Egypt originally, Professor Sherif Ellozy, who's going to cover challenges in vascular surgery education in United States experience.
Okay,
Sharif?
thank you again to the program committee for inviting me to speak. There are a number of challenges that we face in training surgeons in the United States. In the current environment with work hour limitations of 80 hours a week, there's a continuous expanding knowledge base, and there are a significantly decreasing number of open cases. The traditional apprenticeship model of training really is not satisfactory in terms of training technically excellent surgeons. When they look at the, when you think about vascular surgeons, open abdominal aortic aneurysm repair is probably the one procedure that separates us from all the other fields. Cardiologists do peripheral interventions, cardiac surgeons may be involved in thoracos. We have people doing dialysis access who maybe not vascular surgeons, but the open AAA is the defining procedure for our specialty. And it is, the number of cases has gone down significantly in the last 2 decades with the advent of endovascular repair. This is a paper that came out of Michigan where they were looking at the number of open aneurysms performed in the Medicare database, and they compared that to the number of trainees per program. And what they found out was that by 2014, about 40% of programs across the United States had approximately 5 open aneurysm repair per trainee per year. And so senior residents, they were doing perhaps 5 open trainees. In a 2-year fellowship, 10 open aneurysm repair, the question is that adequate or not? This deficit came to the attention of the Association of Program Directors in Vascular Surgery in 2019. Dr. Tassiopoulos presented this, and one of the things that was most alarming was that there were programs where people had 0, their graduates had 0 open aortic procedures, and so this is a real problem in the United States. They suggested maybe lowering the requirements. That sounds like an unsatisfactory solution. Then the question is, are there any programs that the APDVS could sponsor, such as teaching courses in simulation, or do we send our trainees elsewhere, maybe abroad where they have higher numbers? But the most important point is that we're not looking at numbers. Numbers are only a proxy for clinical expertise. We really want to develop experts in open aneurysm repair. And so when you think about clinical competence, there are a number of factors that go into performing this well. There's the procedural skills, there's situational awareness, critical thinking, communication skills, clinical reasoning, teamwork, and problem solving. And you want to train your trainees in all these aspects. So how do we acquire expertise? This is Malcolm Gladwell in his book Outliers talks about the acquisition of surgical skills, and he developed this concept of the 10,000 hours. And so they talked about looking at artists like the Beatles, but the explanation is not so simple as the amount of time spent acquiring a skill, or else everybody would achieve expertise through experience. And so when you drill down on it, his work is based on the work of a psychiatrist, Anders Ericsson, who looked at high-performing individuals. And what he found, what differentiated them from everybody else, is that they engaged in what's called deliberate practice. And so they would focus on a task, they'd have a specific goal, they would get coaching, they would listen to their feedback, they would build a strong foundation, and be focused on their own improvement. And they often used mental representation to think about what they were doing. He looked at, for example, musicians. So this is in the Berlin Academy of Music, and they had professional pianists. And he tried to identify characteristics that separate the real experts from the average musician. They all spent approximately the same amount of time in music-related activities, but the experts were the ones who engaged in solitary practice. They got feedback from their trainees, and they focused on specific tasks to improve their skills continuously. And so that you really want to get beyond the autonomous stage where you're doing tasks like tying your shoes, where you don't have to think about it, there's not really much challenge, to doing higher level, more complex tasks. And so how do you do that for training people on open AAA with lowered numbers of cases around? One thing you can think about is breaking down the operation into its essential components. So there's vascular exposure, there's the setting up of the retractions, there's the actual reconstruction, and there's troubleshooting and intraoperative decision making. And so you can individualize the training and maybe use certain alternatives to try and focus on those different tasks and break it down and to develop expertise. So for example, we can get our trainees in the cadaver lab. You can use alternatives such as oncologic resections and spine surgeries to get them comfortable with the vascular exposure and dissection. In terms of reconstruction, there are some high fidelity simulation models that we have available to us, and I think there's a role for them. And then in terms of the troubleshooting and intraoperative decision making, you can have oral board type questions, team-based simulations, other things to mimic the intellectual challenges that you encounter during open repair. So this is just an example of the pulsatile flow model. These are a couple of my fellows in the middle of the pandemic, and it's actually got pretty good fidelity in terms of sewing in a hole, setting up your retraction, and doing the reconstruction. So fellows can do this before they do the case and get comfortable so that when they're in a more high stress situation, it is more second nature. The simulation allows for deliberate practice so they can focus on specific aspects of the task. You can also expose trainees to rare or complex situations which they don't encounter in everyday clinical practice. And you can also develop some standards to compare their performance to. Okay? However, there are some downsides to it. It's costly and it's resource intensive when we talk about faculty availability. It needs to be integrated into your overall curriculum, and so it should be done at a regular basis if you're going to make it effective. You should have clearly defined outcomes and benchmarks and increasing levels of difficulty so everybody's challenged. And it needs to be a valid tool. So what research is there about? There's not a lot of research out there for open abdominal aortic aneurysm simulation. This is a paper that came out of the UMass Institute where they had a relatively inexpensive simulation setup, but it mimics the geometry of sewing in a hole. And they looked at the effect of instruction on how people perform. And so residents were randomized either instructed by a lab technician or a faculty member. They did a pre-test, then they were filmed, and then they underwent instruction, and then they repeated the task and were filmed again. And the evaluation was blinded. And they had two important findings from the simulation. One is that faculty training is better than simply having a lab coordinator. When they looked at the change between pre-test and post-test performance, having a faculty member giving feedback was essential in terms of improving the quality of the outcomes. And two, for their simulation model, the mid-level residents gained the most benefit from it.
Sherif is 1 minute.
Yes. So junior level residents didn't gain a lot of benefit. The senior level residents, maybe this model was a little too simple. And so you need to tailor the simulation to the level of the resident. And I'll talk about this last paper in my last few seconds. This was a more recent publication coming out of Scandinavia looking at the Operate tool where they broke it down into 8 steps. And they queried 16 novices and 9 experienced surgeons. And they actually had very high internal consistency and interrater reliability. And you can see that the novices, the experts performed significantly better than novices. Their pass level was very high, and so they had only 1 novice who passed, and 6 of the 9 experts actually failed. So I think they need to idealize where the pass-fail score will be. But in conclusion, you know, we need to alter how we train our residents, and there are alternatives available, including simulation, but a deliberate practice should be the focus, and there's an evolving role for skills, courses, mini fellowships, and mentorship in new graduates. Thank you very much.